used to be. Thank you. It's much better than it used to be, but it's not perfect. And so when someone receives chemotherapy, traditional chemotherapy, drugs like melphalan, the drugs like cyclophosphamide and so on, the plasma cell count in the bone marrow does decrease from this large number to this small number, but so also do some of the normal bone marrow elements, so that some of the side effects we see in that situation are due to a decrease in the bone marrow cells. Again, red blood cells, so anemia, white blood cells, a risk of infection, and platelets, a risk of bleeding or a need for transfusions. And that's the first step we see with chemotherapy. The next thing is then the waiting for recovery. So most chemotherapy, not all of it, but most chemotherapy is given in cycles. And the first part of the cycle is when one receives the drug, results in a decrease in the bone marrow elements, both good and bad, but hopefully more so of the bad cells than the good cells. And then during the recovery phase, these cells grow back, and the success with chemotherapy is measured in the extent to which the good cells recover, but the bad cells do not. And this is the complete scheme for that. When one is using targeted, so-called targeted therapy, the idea is to find a drug or a treatment which selectively, extremely selectively, will hit the bad cells but spare the good cells, so that you don't have to pass through a phase where the cell count is low. And these three medications, as you heard previously, are the ones that are perhaps most in use with that type of approach. Although in a sense, steroids like dexamethasone were in some time past, as far as the bone marrow concerned, a fairly selective treatment, because they would hurt the myeloma cells while sparing many of the good cells. So in that type of approach, an ideal targeted therapy will eventually destroy all the myeloma cells and leave out the good ones so they can grow back, but without passing through a phase of low cell counts, which is hurtful. Now to bone marrow transplant. How is bone marrow transplant different from all this? In concept, it's not really different. It just uses some of these things that are already available. So in its simplest form of an autologous stem cell transplant, which means we're going to use stem cells from the patient themselves to replace them when they need it. The first step is it's a step that has been termed mobilization, or sometimes it's called priming of stem cells. In the past, stem cells had to be collected from the bone marrow. The stem cells are those seeds, if you might call them that, which when put back into an empty marrow, have the ability to replace the blood elements in the marrow again. And they're called stem cells or blood or marrow stem cells for that reason. But in the past, these had to be removed mechanically from the bone marrow and stored so that they can be used to restore the failed bone marrow or the empty bone marrow, so to speak. Now, however, using certain medications, including chemotherapy, these cells can be made to move a little bit from the bone marrow and circulate in the bloodstream. It's almost like somebody came to a big apartment complex or something like that and drove out all the cars that are sitting in the garages and over there and said, go out into the streets and circulate and come back again in the evening or something like that. So that's what mobilization does to these cells. It releases a number of stem cells from the bone marrow into the blood. What can we do then? There are these devices called cell separators in a procedure called apheresis. But what these cell separators is, they work almost like a dialysis machine for blood cells. In dialysis, you're really looking at the liquid part of blood, which is the serum. But the cell separator works on the cellular part of the blood. And what it does really is to run blood, draw blood from the patient, run it through the machine, separate the blood into different types of cells, and return everything else back into the patient. So it's a run. This usually takes about 4 hours per procedure. Most patients can accomplish this in 2, sometimes in 3, but occasionally in more sessions, and it's an outpatient procedure. So these cell separators are able then to take out some of these good cells into a collection that we call the stem cell product. The patient then goes to the next step where they receive a very high dose of chemotherapy. And this is where most of the side effects of transplant are going to come from, because the chemotherapy here is many times the dose that would usually be used in regular chemotherapy. It's, I'm told if you win the lottery, I've never won, and I guess you need to play to win, so I'm probably never going to win. But I'm told if you win the lottery, they approach you and they say, do you want all your money now, or do you want your money in a little bit at a time? And in a sense, this is what transplant tries to do. It tries to take the chemotherapy, which would normally have been spread over a long period, weeks, months, maybe even years, and condense it and give it in a safe way within 2 hours or 3 hours. This is a very high dose of chemotherapy. And the drugs are specifically chosen to have very few side effects outside of the bone marrow. So these are drugs that, although they do have side effects in the bone marrow, and I'll mention that in a minute, they are chosen to be fairly safe on the heart, on the brain, on the lungs, on the kidneys, and so on. That's how those medications are chosen. And today, melphalan, which is a very old drug and still very useful in multiple myeloma, probably remains the best, or one of the best, and certainly the most commonly used drug in this situation. So this is a very high dose of melphalan. What happens to those patients? The bone marrow becomes fairly empty. So the bone marrow gets cleared of cells, good and bad. This is completely empty, to the extent where if that patient were left alone, the bone marrow would never recover. And so their blood compartment would never recover if left alone, except that those stem cells which were collected ahead of time can now be reinfused back into the patient and hopefully restore the bone marrow. Well, why is this not a perfect procedure? I don't know if you saw it, but lurking somewhere in the empty, so-called empty marrow, and hidden where